Good evening and welcome to this evening's step-by-step webinar. It's great to have so many participants and we hope that you're all keeping well. This evening we are delighted to host a webinar on new dimensions in surgically facilitated orthodontics, expanding piezocision beyond accelerated tooth movement, as presented this evening by the leading research and clinical team based at Harvard, Boston and also London. This webinar will serve as an introduction to the topic, and we plan to run a session, a 10-session online course in autumn to cover all aspects of principles, indications, and the technique of piezocision, and some more details of this later on. This evening's talk will be around 50 minutes, followed by 10 minutes for questions and answers. We'd be most grateful if you do not take screenshots or record this webinar. So this evening we've got three eminent speakers, and it gives me great pleasure to introduce the first of these speakers. Dr. Serge Debart is Professor and Chair of the Department of Periodontology at the Boston University Henry M. Goldman School of Dental Medicine. He has been working on surgically accelerated orthodontics for the past 14 years and developed piezocision in 2009 as a minimally invasive alternative to the existing surgical procedures. Now, Dr. Debart, if I may now hand over to you to share your screen and start us off, please.
Thank you, Jared. Let me see if I can master this. Is this working?
Yeah, that's looking very good.
Fantastic. So again, thank you and and hello from Boston. It's about 2 p.m. here. I don't know where you are and what time is it at your place, but I think it's going to be an exciting seminar, and I would like to thank Step by Step Surgery for allowing us to show you some of the new things we have done with piezocision and accelerated orthodontics. So the seminar today, or the introductory seminar, is named New Dimensions in Surgically Facilitated Orthodontics, Expanding Piezocision Beyond Accelerated Tooth Movement. And as Jared said, this will be followed later on with another more comprehensive course. So stay tuned because this information is coming up. So what is piezocision? Piezocision was developed in my department about 12 years ago as an alternative to the more aggressive corticotomies that were developed by the Wilcos, and was first published in the compendium in 2009. So piezocision is a minimally invasive, surgically facilitated orthodontic treatment, if you will. It's called piezocision-assisted orthodontics. So what we do interproximal incision like so here, and only on the buccal side. And then we use the piezoelectric knife here, the piezotome, to do the decortication interproximally. So what this does, this starts the regional acceleratory phenomena, also known as RAP. And the hallmark of the RAP is that it's a bimodal phenomena, which is demineralization followed by remineralization of the bone. And it's during this demineralization phase that the orthodontist can then move the teeth in the direction that he or she wants. It's also a very localized phenomena that's important to remember. In areas where we need some bone or soft tissue to expand, the anatomical structures, then this is done very elegantly with a tunneling technique, and we can either put bone or soft tissue in this tunnel. So let's look at what happens to the bone after piezocision. So this is an animal model that these things were done in my laboratory. Here on the top, you're going to see the rat, the hemijaw of a rat. This is tooth movement alone. It's a micro CT, and you can see how after 4 weeks, the first molar here has moved mesially forward, creating space here between the first and second molar. Now, if you were to look at the same thing, but having added piezocision to it, you can see an incredible amount of demineralization that has happened in the bone around this very first molar, as well as the larger space that has been created with the first and the second molar. And this was published in 2010. Now, what happens to the bone that we graft, you might ask? Again, after tunneling, the bone is being grafted, a couple of sutures, and this patient was seen two years later. So this is a CT scan before and after, and we can see that we gained about 1.5 millimeter of buccal bone, and that's something that we see regularly. Now, piezocision was originally described or labeled as an orthodontically guided surgical procedure designed for the orthodontist and performed by the periodontist or the oral surgeon. Nowadays, it's going to be an orthodontically guided surgical procedure designed for the orthodontist and the restorative team and performed by the periodontist or oral surgeon. And my colleagues, Dr. Keser and Dr. Nelson, will show you cases of these two. Back in 2012, we had the pleasure, Dr. Keser and myself, to share the stage with this man here. This is Bill Prophet. Bill Prophet is a giant in orthodontics. You know, as I always say, the orthodontist sleep with two books. One's a grabber, the other one is the prophet. And so this is Bill Prophet, and we were in Rome sharing the same stage. And he listened to our presentation and was pleased enough that he asked us to participate in his book, and I sent him cases, and he was kind enough to mention us. So we had this great backup by one of the giants of orthodontics, you know, and that made us feel very good. Yet, when you look at literature, there is some conflicting results, the conflicting opinions, and that's why I have this very nice slide from Genesis that says a land of confusion, because indeed it is very confusing when you read the literature about piezocision. So the next steps, you know, in the future lectures, will be explaining to you and helping you understand what is written in the literature. So here are the three first things that comes to mind. Why such confusion? First, there's an absence of consistency in terminology. Okay, a lot of researchers around the world are using piezocision, but are not mentioning it with the name piezocision. So it's very difficult to find those articles, you know, or find all the articles about piezocision in the literature. The second is the absence of consistency in a set protocol. It seems like everybody is putting their sauce in this technique, you know, and creating their own version of the technique, and then complain if it doesn't work. Well, we had set a protocol, you know, that works, and if you don't follow it, then of course you'll expect the same results. Finally, I also found that there was a lack of understanding of the biology behind the technique and how you should use the technique. And that's basically why we decided to have this course which will train you to understand exactly what the biology is behind piezocision as orthodontics, as well as the proper technique, so that you can use the protocols and have the same results that we will be showing you here. So here, a case in point, this was from AJODO of a couple of years ago, I believe, randomized controlled trial. The effectiveness of traditional corticotomy versus flapless corticotomy, mini screw support, unmasked retraction, etc., etc., etc. So when you read this, at least when I read this, and I see traditional corticotomy, the first thing that comes to mind is Orthodontics, because they were the first ones who started doing this, you know, surgically accelerated orthodontic procedures and called it corticotomy. Yet, if you were to flip to the magazine, what you would see here is piezocision, okay? But nowhere in the paper piezocision is mentioned. Also, you will see that, you know, if you look at closely to the picture, you have this burned mark here on the soft tissue. So it's a Piezocision that was not done according to the protocol that we have put forth. We have to have a certain type of instrument, certain frequencies. The water has to be right. I mean, there's lots of things that go with this. Okay, so you have to perform the technique properly to be able to assess the results and have consistent results. Besides the terminology, of course. Another case in point is this paper that was by Charavet and co-worker from University of Liège. And this is actually in a very high impact journal, Journal of Dental Research, which for dentists is one of the very, very high impact journals, where she did compare Piezocision orthodontics versus non-Piezocision on 24 patients. And she actually is the first one that was able to put a real number on how much faster treatment is being done if you add Piezocision to your conventional orthodontic treatment. And this showed a 43% reduction in orthodontic treatment time, with no increase in root disruption, no recessions, and a great patient's acceptance. That was back in 2016. Then in 2017, a paper by Uribe came out doing something similar, but with a completely different conclusions, where he stated that no significant difference in the time required to correct mandibular crowding was shown. So this is very, very confusing. So, but let's have a look at the paper per se. If you look at the paper, the first thing that when you start reading the technique per se, which here they call piezotome corticision procedure, another terminology that's different, they will tell you they used a modification of the technique described by Dibar and coworker, and the depth of the cortical incision was limited to 1 millimeter. So they are not doing the procedure as it is described by us. Okay, we emphasize the need to pass the cortical bone to get into the medullary bone. So a minimum of 3 millimeters is needed, and that's what we have been saying and writing. So of course, if you don't follow the protocol, then you cannot have the same results. Having not the same results and publishing that, doesn't make much sense, because now you add confusion to the mix, and nobody understands anything at the end, really. So let me show you why it's important to pass that cortical bone and be in the medullary bone. This is all based on science in my lab, on animals studies. Here you have a rat, the femur of a rat. Here you have a deep decortication, so this deep piezocision versus a shallow piezocision here on the femur of the animal. It's controlled with the CT scan. Here you can see that on the left-hand side, we have the shallow decortication, so we are not passing the cortex, versus on the animal, we have going through the cortex with a deep decortication. This is at 3 days. At 7 days, we are seeing here at 7 days in the shallow site, a modification of the bone, and almost it start to heal in a way. If you're looking at 7 days, the deep site, then you see a completely different picture. You can see a lot of modification here, a big bone turnover that is happening. So a very complete different picture when you pass the cortical bone versus when you just, graze it. And this is further, clear if you have cross sections of that tibia, and you can see here, the activity that's going on once you pass the cortical bone versus, if you just scratch it. And this was published in the Angle Orthodontics by one of my master students, Dr. Jeremy Kernitsky. Now, to add a little bit more confusion to the matter, not all instruments creating corticotomies have the same effect on the bone. This was presented this year, actually, at the AIDR meeting, this year in Boston, by one of my master students, Dr. Di Battista. Here we are using deep learning, so using artificial intelligence to see the difference in terms of demineralization and porosity when you're using the piezoelectric knife in the deep cuts versus the burr in deep cuts, the sham, which is just reflecting the periosteum and putting it back, and the control, which is doing nothing. So you can see right away that if you were to compare the piezo versus the burr, the piezo will give you more demineralization at the frequency that we are using, because the frequency is very critical. Not all frequency will give you this, versus the burr, okay? So depth and instrument do matter. That's something that I would like to people to understand. And reading the literature, one has to be cognizant of that. And we have all this confusion because people are not following protocols, are using wrong terminologies, and therefore creating chaos everywhere. Our goal is to straighten this up, and in the next lectures to explain that to you, as well as give you a good sense and a proper understanding of the technique and the protocol, so that you can achieve results that you have been seeing for the last 12, 13 years. Lastly, I just want to say a few words about this root resorption comment that comes here and there. AG Audio put out this paper a few years ago where they were comparing Piezocision on one side versus not on the other side, and they were extracting the teeth. And they came up with this number that we have 44% average increase in root resorption if you were to do Piezocision. Now, okay, look at the numbers carefully. 14 patients, so a small group, 4 weeks study, so a very short study. The Piezocision teeth have 0.4 millimeters square of resorption versus the control teeth who have 0.3 millimeters square. So basically, if the paper is correct, then you have a 0.1 millimeter square more resorption, quote unquote, which is 1/10 of a millimeter. I don't believe that results in anything dramatic clinically, but let's just assume that it is. Now look at the paper as well. It says that 4 participants demonstrated less root resorption with Piezocision than without. So there's a lot of inconsistency and a lot of variability in terms of root resorptions. And I don't believe that it is a phenomena that is linked really to Piezocision. Now, also, if you were to read the paper in depth, you will see these marks here, these marks of the piezotome on the root surfaces. And without being facetious, if one of my students were to do that, I will send him back home and kick him out of the program. Seriously, you know, you have to be knowledgeable of the anatomy, and seriously want to go at it and be careless and create this lesion on the root surface, to do that. That's not what happens usually. If you know your anatomy properly, this does not happen. Anyway, so I was pleased that a month later there was a rebuttal in that journal by a group by Ku and coworkers who said that they were they looked at it carefully, they read the analysis, and the conclusion was that there is no statistical difference in root resorption between the piezo treated and the untreated sides. And a reader who only has time to read the abstract will be misled to believe that Piezocision causes significant inflammatory root resorption, when in fact the study data do not support this. So I will leave that at this today. Again, important to read the papers and to read them in depth. Back in 2014, actually, a group from Italy, very, very creative, came up with the idea of using guides, to make the incisions so that you could avoid roots and be very, very safe for doing that. And this was published by our group. Dr. Milano, whose wife is an orthodontist, he's a periodontist, came up with this idea, and he published this new guide in 2014. Then they improved the guide for Piezocision to have this more sophisticated look. And this is how it looks in the mouth. And nowadays, if you were to come to my department in Boston, this is what we are doing. we are using navigation to do Piezocision. That's called the dynamic guided Piezocision. And we do this for all our cases. Do you need it? No, not necessarily, but it gives an extra level of safety and actually fun, because using navigation is like using the GPS when you're in your car. What you're seeing here is one of my residents doing the piezo cuts using navigation. And at this point, he can not only avoid the root surfaces, not place the cut in between the root surfaces, even in areas that are very, very, very close, but also know how deep to go and past the cortex to be into the medullary bone. So basically, it's like using a GPS where the car is this piezotome and the map is the CT scan. And as you are doing your procedure, you can, at any time, in real time, change the course of your osteotomy. So lots of fun. Then finally, I like to also say that the case we're going to be showing in the future, we have added technology in the multidisciplinary cases where you use perio, ortho with Piezocision, prosthetics, and also the robot. We have the Yomi Robot, which allows us to place with a perfect precision implants in cases that have been treated by the periodontist, the orthodontist, and now the prosthodontist. As you can see here, this is one such case that was treated with Invisalign, where there's the space is at the premium. And this robotic surgery allowed us to place the implant exactly in the position that we wanted to place with a 0.5 millimeter of error at the most. So stuff that I will be showing in the future, that's also quite cool. Finishing my talk here, Piezocision has come from being a method, an alternative method to the Orthodontics, increased speed of movement, strength by strengthening the periodontium, to controlling anchorage and being able to challenging orthodontic tooth movement, and now to expanding to multidisciplinary treatments and much more, as Dr. Nelson will be talking next. I like to think of Piezocision or Piezocision assist orthodontics as like a game of chess, where the orthodontist is the strategist or chess master who controls the anchorage value of the teeth by altering mineralization, demineralization in various parts of the jaw, decide the timing and the extent of the Piezocision, where the teeth are going to go, when they're going to go, how many times do we do the Piezocision. And if we keep this analogy with chess, then I found that using Piezocision assisted orthodontics in your daily life as practitioner, it will really boost your planning skills, as we can see here the slide. It will really elevate your level of creativity, deepen your focus when you're treating, and develop perspective. I think this was taken from the chess games, but I think it's applicable to us if we are to use Piezocision assisted orthodontics, in daily practice. It's a lot of fun actually. When you start. And finally, I will leave you with this very, very last slide, which I tell my residents. This is from a museum in Switzerland. Max Ernst, a surrealist artist, who says, cages are always imaginary. And that's true, it's the mind. The mind is a phenomenal tool, and thinking outside of the box and being creative, it's expand you, and you find new ways to treat patients, which are satisfactory to your patient and to yourself. And with this, I will pass it to Dr. Nelson.
Thank you very much, Dr. Dibbett, for a really beautiful illustration of the principles of Piezocision and some lovely, robust evidence to back that up. I'm just going to stop your sharing there. Thank you very much. And there's some people raising their hands. Just to remind, we'll have Q&A at the end of after the third talk. There'll be about 10 minutes for that. Moving on to our second speaker now, Dr. Donald Nelson, who, Don, if you can start trying to share your screen. is Assistant Clinical Professor in Orthodontics at the Harvard School of Dental Medicine. Dr. Nelson has incorporated piezocision in his clinical practice for over 10 years and has lectured on the subject of piezocision in contemporary orthodontics, both nationally and internationally. So, Dr. Nelson, if you don't mind.
Thank you very much. And it's wonderful to see so many people attending. And thank you all for being here today, or I should say it's tonight for most of you. It's today for us on the East Coast of the United States. I wanted to start by thanking Mehmet and Jared for helping us put this presentation together in fairly quick order. So this presentation will give a brief look at some of the material we'll be covering in the 10-session course that'll be given in the fall. And today, of course, we'll be sort of skimming the surface of what we do with these cases. And in the fall, of course, we'll be showing not only many more cases, but in much more depth in terms of the protocols that we apply to these cases and to the steps in treating each and every of the cases themselves. So my topic today, and has been in a lot of our lectures, is piezocision in contemporary orthodontics. I am primarily a clinical orthodontist. I teach at a couple of institutions, but I'm primarily a clinical orthodontist, and I feel that I've been very fortunate in having discovered piezocision and being able to employ it in my practice and to work so well with Dr. DeBart. So most non-orthognathic corticotomy techniques are directed at accelerated tooth movement. And for us, piezocision started out as a means to accelerate tooth movements. But we found that in treating these less complicated cases, we were achieving results that exceeded our expectations. So we began to broaden out the scope of cases that we began to apply piezocision to. And we found that, once again, our expectations exceeded, our results were exceeding our expectations. We began originally using microperforation such as Propel, and I found I was not getting the same results with Propel. Wilcodontics I felt was more invasive than most of my patients wanted and was rejected by our patients. But as we started using piezocision, we found the rate of acceptance to be excellent. So we began applying piezocision to cases that involved distalization of buccal segments in class 2 adults, bite opening in severe deep bite cases, severe torque issues, posterior cross bites on adults, where maybe we would have considered surgically assisted expansion or SARPI, and we were able to achieve excellent results with the piezocision. Posterior open bites and alveolar insufficiency, which I think will be of particular interest to the periodontists. Insufficient alveolar bone for implants. Likewise, we developed the alveolar ridges in cases where they were insufficient for implants. Space closure in severe spacing cases, impacted teeth, cases where bisphosphonates had been used in the past for osteoporosis, and we were concerned about our ability to move the teeth. Anterior open bites, enhancing movements with clear aligners, bone augmentation of thin alveolar ridges, and basically we constantly are thinking beyond just accelerated tooth movement. And for those of you who begin to employ piezocision or have been using it, we invite everybody to be as creative as possible in the use of this new tool. So Dr. DeBart and I have treated over 80, maybe at this point close to 90 well-documented cases with piezocision. And in these sessions, I will share many of these difficult adult and adolescent cases. So why piezocision? So after using microperforation with Propel and Wilcodonics, which simply traumatized the alveolar bone, we started to observe much more profound movements in difficult adult cases with Piezocision. We realized the difference is the effect of the oscillations produced by the Piezocision on the medullary bone and the increased wrap effect that it produces. So we not only are seeing changes in the alveolar bone, but we're seeing changes in the actual modification of the medullary bone and the underlying skeletal components. Okay, and I'll just say that again, I'm primarily a clinical orthodontist, and my focus in today's presentation and the sessions in the fall will be Piezocision and contemporary orthodontics, along with Dr. Keser, and we'll be presenting a lot of cases. Today, I'll be sort of skimming the surface to give an overview, but in the fall, these cases will be presented in much more detail, and many, many more cases will be presented as well. We'll also highlight the protocols and the steps of those treatments when we get into those presentations. So non-orthognathic dental alveolar corticotomy, again, was directed primarily at accelerated tooth movement. And this is the list that we've been developing as we've gone along over the last 10 years in using Piezocision in treating these orthodontic cases. And like I said, amongst the list here is insufficient alveolar bone for implants and cases where bisphosphonates have been used in the past, bone augmentation of thin alveolar ridges. So our application is not only pertinent to the orthodontic treatment of the cases, but in the multidisciplinary realm as well. So this is, I think, sort of where we were up to, right? And we said, think beyond accelerated tooth movement. We've treated over 80 well-documented patients with Piezocision, and we'll share many of these cases of difficult and adolescent treatments in the sessions. So why Piezocision? Again, because the oscillations that are employed with the Piezocision have a extreme wrap effect on the medullary bone over and above the trauma that just Propel and Wilcodonics do. So my note here is, while I do a lot of clear aligner treatment, and I use a lot of aligners, especially on adults in my practice, the focus of this presentation will be on fixed appliance treatment in challenging cases. We find that many adults are receptive to fixed appliance treatment if they understand the result will be more ideal. And this seems to be especially true for the adults who have waited until they're older to pursue treatment. And many of these patients can well afford whatever treatment they would choose, but they're willing to go with, with fixed appliances. And we find we're getting excellent results in these very challenging cases. So let's look at sample treatments. Distalization in class 2 adult cases, difficult deep bite adult cases, open bites, severe crowding, transverse deficiency cases. And that will be the group that we'll be looking at today, but in the fall, we'll be expanding that sample of cases to many more types of cases, many more categories. So let's look at a typical distalization in a class 2 adult case. This is Alicia. Alicia came to us, she's about 59 years old here. She had been in clear aligners and Invisalign for about 1.5 years. She's a very intelligent woman, and she said that, I went into treatment only because I wanted my bite corrected, and I don't feel like it's being corrected. And my dentist agreed. So she came to us. And as you can see here, her molars on the right are end on class 2. On the left, they're nearly full cusp class 2, and the canines are class 2. So I told Alicia, you have a couple of options. One is we could extract teeth to improve her occlusion, but she preferred not to extract teeth. And I said, you know, I think we could distalize you very well if you're willing to pursue piezocision. And she was receptive to that. And here you can see the very limited piezocision procedure that Dr. DeBart did to help us treat this case. So once again, we stress how minimally invasive compared to full Wilcodontics procedure piezocision is. This is 2 days post piezocision. And here, if you'll notice on this photo on the left, the piezocision sites are barely noticeable 2 days after the procedure. On the right, in the composite montage, you'll see a little bit of the mechanics that I use: a simple Nance button, straight arch wire, compressed coil, supported by class 2s off the holding arch on the lower. And once again, if you see the arrows, those are the piezocision sites 2 days post piezo, barely noticeable. I've had patients go back for a second and a third procedure because they found it to be, I wouldn't say enjoyable, but not objectionable. And so here is her case finished. And you remember how deep the bite was and how class 2 the buccal segments were. And she was very pleased, and she's sent us probably 3 or 4 patients since she completed her treatment. Let's look at a difficult deep bite adult case. If you look at the x-ray on the right, you'll see this is a hypodivergent patient. He's a 60-year-old male with very strong musculature. If you look at his dentition, what you'll see, he's got 110% anterior overbite. And as difficult in this case, he's got very detorqued or retroclined upper anteriors. And the angulation of those upper anteriors cannot be corrected only by proclination. They need actual torque. So let's see what happens in this case. If you notice, the segment of photos at the top shows the case before piezocision. We had just bonded the upper arch. We have a very light wire in and anterior bite ramps. The anterior bite ramps are opening him up posteriorly, and our goal here is to erupt the posteriors. In other words, to increase the posterior alveolar height. 2 weeks post piezocision, you can see the posteriors coming together. And look at this 6 weeks post piezocision. To our surprise, it happened that fast. His posteriors are in occlusion. This was done without posterior vertical elastics. He has no brackets on the premolars. This is eruption of the posterior segments coming together as a result of the stimulation from the piezocision procedure. This is Larry at the beginning of treatment, and here he is at the completion of treatment. And again, just as difficult in this case, if you look at the Ceph down below where he started to the finish, while some of the change anteriorly is proclination, most of it is torque. And in the presentation that we give in the fall, I will document that for you through superimpositions and go through in depth how we got to this result. The net change in the anteriors is 33.4 degrees. Again, on a 60-year-old adult. Let's look at an open bite case. In this case, we wanted to avoid orthodontic surgery at the patient's request. She's a 41-year-old female. She had TMD issues, which were demonstrated by muscle tenderness and some internal derangements of the joints. You can see she's got a posterior crossbite tendency. We had originally talked with her about a Lefort procedure, which she declined, and possibly a corticotomy with a surgically assisted rapid palatal expander, which she also declined. She said, I'm willing to compromise the end result if I can do something less invasive. So I talked with her and I said, you know, I think, Sharon, we could probably improve your occlusion a lot and maybe stabilize it with splints if you're willing to consider Piezocision. What you'll see as you look at her ceph is this is not just a dental alveolar problem, but you'll see the tipped palatal plane and the hyperdivergent skeletal pattern. Once again, we stress Piezocision is minimally invasive, which is why she was receptive to it. This is the Piezo procedure that we asked Serge to do. You can see in this case, there were 4 incisions. But what's interesting about the Piezo procedure is that even though we did not have any incisions done in the front, the oscillations radiate, if I could use that term, through the entire medullary bone of the maxilla. And we see changes all the way through the dental alveolar process. So our goal here was somewhat unique in that I wasn't looking to erupt the upper anteriors. I was looking to intrude the posteriors. There's the Piezocision, 2 days post Piezocision. Again, you could see the Piezocision sites are almost unnoticeable. We had started with posterior crossbite elastics following the Piezocision procedure, and we were using a mandibular splint to stabilize her joints and to improve her muscle, her extracapsular problem of the TM joints. The splint was used for TMD and for the vertical change that we were trying to develop while the transverse was corrected. Here you'll see 11 months post the Piezo, if you notice the change in the occlusion. Some of this, as you'll see in the more expanded presentation, is extrusion of the upper anteriors or leveling of the upper occlusal plane, but quite a bit of it is posterior intrusion aided by the Piezocision procedure. This is her completed case. No TADs or plates were needed in this case with Piezocision. And by the way, no anterior elastics were used for eruption of the anterior segments at all, because that tends to produce a lot of instability in the final result. This is primarily leveling of the upper occlusal plane and intrusion of the upper posteriors. Again, no plates or TADs were used in this case with the Piezocision. Let's look at a severe crowding case. This is James. He's a 40-year-old male, and at the patient's request and the dentist's insistence, we were asked to treat him non-extraction. Now, normally, I would extract a case like this. One of the concerns, of course, is the constriction of the maxillary arch and being able to handle that. He also declined surgically assisted expansion. So SARPI was off the table, extractions were off the table. And one of the major concerns that I had in his case was that, as you can imagine, if we begin to align these teeth by proclining, we lose incisal guidance entirely and we leave him without good function. This is his case at the end. If you compare again the maxillary arch, the alignment, we were able to complete this case with the aid of Piezocision, no surgically assisted expansion, no extractions. Now let's look at a case involving tunnel grafts. And tunnel grafts have been an amazing gift in certain orthodontic cases and an amazing gift for the periodontal health of constricted maxillary arch type orthodontic cases that we treat. So this is Sarah. She's approximately a 30-year-old female. If you look at her maxillary arch, you'll see it's very V-shaped and extremely constricted. And as a complication, she had had a repaired cleft. Normally, we would have treated her with surgically assisted expansion and a mid-palatal corticotomy. The problem is with the repaired cleft and the scar tissue that's there, we were really reluctant to take the risk of doing that procedure. So I talked with her about Piezocision, and she was receptive to it. But the other concern here is that if we're going to treat her without the mid-palatal corticotomy to widen the maxilla skeletally, we'd be doing some buccal tipping of the posterior teeth, and the cortical bone was already extremely thin. So what we needed to do was facilitate the movement of the teeth and augment the bone. So let's see how that was done. This was done through a combination of Piezocision and the tunnel grafts, as Dr. DeBard had showed you in his presentation. And the wonderful thing that we find about this is that the combination of the Piezocision, which causes bleeding and stimulates a wrap effect, with the graft allows the graft to integrate in ways that we normally don't see. So let's see how she finished up. This is the way she started. That's the way she finished. And what I'll draw your attention to is two things. One is the dramatic change in the shape of her maxillary arch. And the other thing that I'll draw your attention to is the lack of change in the periodontal structures in the buccal segments. And that again is thanks to the aid of Piezocision with the tunnel grafts in Sarah's case. So again, I invite you all to join us for the sessions in the fall, which will be in much more depth, and we'll go over the protocols in treating these cases and the actual steps in which we treated them. And join us to discover how to treat these cases and many other challenging cases and expand your practice by treating cases you perhaps hadn't thought possible. And for the periodontists in the audience, this case on the right is one such case that we'll be showing in that presentation. Again, thank you for joining us, and thank you, Jared and Mehmet, for helping us put this together. I'll turn this now over to Dr. Keser.
Thank you very much, Dr. Nelson, and apologies again for the technical issue at the beginning. It was a beautiful talk, some great cases to whet the appetite, so thank you so much. Okay, now we have our final speaker for this evening, who I'd like to introduce is Dr. Elif Keser, who is Adjunct Assistant Professor in Orthodontics at Boston University. She has worked extensively in the management of multidisciplinary treatments with Dr. Galip Gorel in Istanbul, as well as Dr. DeBard on Piezocision since 2009. She also is a user of Piezocision in her London-based private practice. So if I can now hand over to you, Elif, for screen sharing, please.
Thank you. Thank you very much, Rod. So let's have a look how this goes. How does it look?
Looks good.
Okay, so thank you very much for everyone for being here. Thank you very much, Memo and Gerald, for organizing this webinar. It's an honor to be together with Dr. DeBard and Nelson in this talk. I'll be quickly going over the orthodontic perspectives of Piezocision in multidisciplinary cases, how we utilize the technique in multidisciplinary cases for our advantage. When Piezocision was first introduced, the main reason for using the technique was to accelerate the orthodontic tooth movement. Long orthodontic treatments were usually associated with inflammation, decalcification, dental caries, and root resorption. Therefore, when the treatment time is shortened, a decrease in the risk of all these negative effects is expected. Now, in the past decade, there has been a significant increase in adult orthodontics all around the world. And adults have different expectations than adolescents, as Dr. Nelson has mentioned. The two main concerns are the length of the orthodontic treatment and also the appearance of the appliances. Now, clear aligners and lingual braces have been gaining popularity amongst adults as they are more discreet, and accelerated orthodontics is getting more popular amongst clinicians, as the possibility of shortening the time in braces helps the patient to accept the orthodontic treatment. For multidisciplinary treatment plans, this trend would involve setting the teeth in correct positions through piezocision so as to allow for faster completion of the minimally invasive treatments. This would mean an increased acceptance of complex multidisciplinary treatments. So the dental team, as long as the dental team is aware of the results that can be achieved by utilizing the piezocision and the speed that it provides, we can achieve better results at the end of dental treatments, not necessarily just with orthodontic treatment. Now let's have a look at how the decortications are being done with the piezotome. Once the mid-root level incisions are made, the piezo tips are used for decortications at the planned locations to a depth of at least 3 millimeters. Again, the depth is extremely important. All the piezocision tips are marked at 3 millimeters, and we have to achieve the adequate depth when we are talking about achieving the necessary wrap effect. So this shows the same patient only 2 weeks after the procedure. The increased mobility can be observed in this video, and this level of increased mobility in such a short time can be alarming for the clinician, but this is what we expect to see after the decortications. This technique can be used in treatment of various orthodontic cases in a generalized, localized, or in a sequential manner. Now, there is no specific type of appliance needed. We can use this technique with fixed braces, buccal or lingual, with clear aligners. A combination of tads or plates can also be used in conjunction with piezocision. Now, one of the important applications is in multidisciplinary cases, because the majority of pre-prosthetic cases are adults, and most of these patients are more ready to accept the ideal interdisciplinary plan when a shorter orthodontic treatment can be provided. Now, I want to share 2 such cases with you very briefly to give an idea of how the dental team can benefit using this technique. So let's have a quick look at an Inline case that was treated in a multidisciplinary fashion. So this lady in her early 40s wanted to improve her smile. Her main concern was the crowding and the general white spot lesions. She had a balanced profile, and she was extremely happy with the position of her lips. So that's one thing she mentioned when we had our initial consultation. She didn't want to change the lip support. She had upper and lower crowding, a significant step between the lower anterior and posterior teeth, and general white spot lesions. The posterior occlusion was class 1. We can see the amount of crowding from the occlusal views, and there was some significant incisal wear, especially in the anterior sections. From the ClinCheck video, we can see the tooth movement planned. The tooth movement planned aimed to resolve the crowding and also to retract the teeth to create the space for prepless veneers. So there were 2 points in designing the tooth movement. And the ideal amount of retraction planned in this case was 0.5 millimeters of the buccal surfaces to leave enough room for the thickness of the veneer. So this was especially important in order not to change the lip support. Now, this plan required 25 aligners on the maxilla, 28 aligners in the mandible, and an IPR around 0.3 millimeters were done in between 8 teeth. I'll quickly go over this video. So what we see here is the mid-root level incisions being done according to the planned tooth movement. Now, we don't have to decorticate in between each teeth. Decortications are planned way in advance. And again, this is a topic we'll be covering during the course. The piezoelectric knife is used for decortications. The depth of the decortication is extremely important in order to achieve the desired wrap effect. So you can see the 3 millimeter depth marks on the piezoelectric knives should completely disappear in the gum to achieve the least amount of decortications that we want to obtain. And at the moment, we can find different types of tips that can be used on the posterior right and left sides in the anterior region where there's root proximity. These are all also designed to provide easy access for decortications. So once the piezocision is done, the patient switches right away to the next aligner and continues with the active tooth movement. So here we can see from both sides, since there was no grafting involved in her case, no sutures were placed. And this is 2 weeks post-op, healing very well. No scars present, and this is her at the end of the aligner treatment. So everything is nicely aligned. The teeth are retracted to give enough room for the prepless veneers. She was extremely happy with just by the alignment, but it did not address the white spot lesions. So Dr. Gürel carried on with the prepless veneers, and we can see the nice result at the end of the treatment. So basically, being able to offer the ideal treatment in a timely fashion helps the dental team, not just the orthodontist. The option to complete the orthodontic treatment in a matter of few months made it possible for this patient to accept the ideal interdisciplinary treatment plan. Let's have a look at another multidisciplinary case. This time it's a case that was treated with buccal fixed appliances. So he is in his early 40s. His main concern is to improve his smile. The reason why he came to the surgery was to get veneers. So orthodontics didn't even cross his mind. He had the upper right canine removed when he was a teenager, and the upper right lateral moved distally, leaving a significant space in the anterior segment. And he was totally against the idea of having braces, and due to his work circumstances, he was very time sensitive about the overall length of the treatment. So what can you do for a patient who is completely against orthodontic treatment? The easiest thing that helps them to understand is doing a mock-up. So the first mock-up was done to demonstrate the result he can get if he doesn't do any orthodontics. So when the mock-up was done and seeing the gaps present, he understood the need for orthodontic treatment. Once the need is understood, then the main issue, the remaining main issue, was to address the time constraints. So we offered him Piezocision as a solution to the time constraint. He had, when we look intraorally, he had spacing in the upper arch due to the missing upper right canine, crowding of the lower arch, a crossbites on the right segment between the first premolars and the deep bite. So the treatment plan was basically redistributing the spaces so that we can give a nice, pleasing smile at the end of the restorative treatment. So Piezocision was done 2 weeks after the bond up, both on the upper and the lower jaw. So the brackets were already in place before Piezocision, and we just continued activating the wires every 2 weeks. And in around 3 months, the spaces are already distributed and cases close to finishing. And in less than 4 months, he was debonded. And a fixed wire was placed, fixed retainer was placed for retention. So in these cases, the retention protocol is the same. We still use fixed retainers and a removable retainer to hold the results. And the second mock-up was done, followed by minimally invasive preparations. And the beautiful veneers were inserted, and a new fixed wire was placed to make sure we hold the results stable. And a very natural, pleasing smile was achieved in total of less than 6 months when we look at it as an overall dental treatment. And he was extremely happy. It met everybody's expectations, and this is him 6 years later. So we can say Piezocision is an invaluable technique which allows the dental team, so not just the orthodontist or periodontist, but the dental team, to provide an ideal outcome without the obstacle of a lengthy orthodontic treatment. And also, as Dr. Nelson has nicely shown, it's not just the speed, but it's also the versatility which makes Piezocision a technique that makes complex tooth movements possible by modifying the bone. So it's certainly not just the speed. Speed is part of it, but the main thing is the change we can create in the bone, and therefore the results that we can get once that change is created. And I would like to thank you all for your attention, and it was a pleasure being here this evening. Thank you.
Thank you, Dr. Keser. Beautiful presentation, lovely cases again, and important, and showing the benefits of multidisciplinary working there with some of Gallup Gorell's beautiful veneers. I'm going to stop you sharing there, Elif, if that's okay. Now, I know Dr. Nelson has got clinical commitments in a few minutes' time. So, Dr. Dibart, you're going to lead the Q&A, I understand. But any participants with specific questions for Dr. Nelson maybe should raise their hands, if that's okay, and you'll be able to unmute yourselves. There we go. Memo, any comments from you whilst we're waiting for participants?
No, I just want to quickly congratulate all 3 speakers for amazingly clear presentations, which really lays the principles incredibly well for a more detailed coverage in their more practically based course. I think I'm keeping an eye on the chat, and I don't think there are any specific questions there. So I think we should be honorable and relieve Dr. Nelson to his clinical commitments, very much appreciating the time difference. And thank you so much for accommodating, for joining us.
Yes, thank you both. And I'd like to thank all the participants that joined us today, and hope to see you all in the fall.
Thank you very much, Dr.
Thank you
Nelson.
all.
Thank you, Don.
Pleasure to present with Elif and Serge as usual. Thank you. My assistant is banging on the door. Okay, thank you again, everybody.
All right, thank you.
I think, Serge, you can take over at this point.
If I must, yes. Yes, if there's anything how much radiation exposure while doing dynamic piezocision? Very good questions. The question, I'm repeating the questions. Let's see, let me just repeat the question. How much radiation exposure while doing dynamic guided piezocision? The only radiation comes from the CT scan, the first CT scan that's being taken. This is it, that's all. Then that CT scan is being integrated into the software of the Navident, which is the navigation system that we use. And then through a camera that is sitting on top of the operator, is part of the Navident system. And the different instruments that you've seen us working, the computer and the software, which is using the eye of the camera, is able to match where we are into the CT scan that has been imported. So the radiation is only when we take the first CT scan, that's it.
Dr. Dibber, can you tell us more about the Yomi?
No.
I'm interested in that.
Yes, the Yomi is a great addition to my department. You're welcome, Rahul. So the Yomi is the first surgical robot for dentistry. We use it now we are the first one to acquire it actually in the US dental school about 2 years ago. And we have been using it extensively in cases where utmost precision is key. When you are very close to vital structures, where you are in the back, in the tuberosity area, for example, there is no good visibility. There's very little amount of bone, and putting a stent in there will impair access. The robot can go in there and place the implant perfectly, you know. In areas where you cannot or do not want to augment bone because of medical conditions, for example, the hand will not give you the precision of the robot. As I said, the robot, you can place the implant with a 0.5 millimeter, you know, leeway of error. So in areas where bone is critical, you know, the amount of bone is critical, you want to place the implant perfectly with some bone around it, then the Yomi robot can help you with that. Otherwise, you'll have to augment because the hand does not have that type of precision, and you want still to have bone around the implant. So that has been how we started it. Now we have moved on to doing full arches, implant placement, as well as restoration. And the robot allows you that because of the precision of the insertion of the implants. And the prosthetic that sits on it then is prefabricated beforehand. And again, because of the precision of the robot, you're able to then match the prosthetics immediately after you place the implant. And that's a great tool for people that come edentulous that can live with teeth, for example.
Excellent. Thank you very much.
Okay.
There's some more activity on chat and also someone with their hand up. So one question on chat here for Dr. Keser. At what time scale and by what means the post-orthodontic retention phase was commenced prior to and during the prosthetic veneer provision?
So it's it exactly follows the conventional orthodontic treatments retention. So right after the brackets are debonded, we place the fixed retainers, and until the restorative treatment is carried out, we also use an S6 retainer at night to make sure that everything is extremely stable. Once the patient is receiving the veneers, most of the time, majority of the time, the prosthodontist removes the fixed retainer, finishes his work. I go in, put the new fixed retainer in, and make new nighttime retainers, S6 retainers. So when restorations are involved, there's always almost always there are two sets of retainers, one right at the end of orthodontic treatment, and then the second one is once the overall treatment is completed, a new, definitely a new suck down, a new S6 retainer. And most of the time, because they cannot work around the fixed retainer wire, is removed and a new one is placed. And we keep it for as long as possible. So just like conventional orthodontics.
Okay, thank you.
Okay, thank you.
Ho-Shang, hopefully that answers your question. Dr. Dibbett, some more on the chat for you, I think.
Okay.
About the direction of movement.
I'm sorry?
It's about the direction of movement of the teeth.
Yeah.
Yeah.
Let me read the question. Would the direction of movement of tooth affect which side incisions are given? No, the incisions are only made buccally. What we've seen on the animal models having cross-sectioned in the maxilla is that if you do the piezocision cut on the buccal, the effect of demyelinization will convey all the way to the palatal side. Okay, so therefore there is no need to go on both sides, just one side is enough. And that's the advantage of the piezoelectric knife at the 30 kilohertz oscillations. That's what we've seen. The concept is, the key is to understand that the piezoelectric knife is another animal. It's not like a rotary instrument. It's not like a chisel, which are mechanical instruments. The piezoelectric knife add to the mechanical injury a physiological components, because at these levels, at the vibration at 30 kilohertz, between 28 and 32, you have the osteocytes talking to the osteoclast and engaging them to get to work. So you have two things happening here, not just mechanical, but also physiological. And that's what people have not understood so far. We are trying to, to explain and write paper when we have time, because we are in academia, we're back down with administrative work, which does not allow to always publish paperwork. But this is the idea. This is what we've seen actually in the animals, and what we've seen in the patients' applications.
Gerard, Dr. Pandit, I think, is waiting with the hand raised. Patient, do you want to ask a question, Dr. Pandit?
Yeah, I would like to ask a question. I don't know whom to address it to, because it's basically I'm a periodontist, and I would like to know that initially we were using very extensive and invasive procedures for piezocision. We used to raise the flaps all through up to the root apexes and make those blocks. And now we have shifted to those small incisions and the small corticectomies. For that, we are using that in our department also. I would like to know whether there is a much difference between those procedures where we used to have those extensive invasive reflection of flaps and using bone grafts, and the type of surgeries we are doing now with small incisions and just going to just break the cortex on the buccal side only. Is there any difference between the time, or is there any difference between the way, the mechanism, how it acts?
Thank you for that question. I'm going to assume that when you say raise the flap, it was the Wilcodontics procedures, with where you go all around the root surface, the root, and make holes on the back of the palatal. Yes, the effects are similar, but they are less traumatic when you do the piezo with the small incision on the buccal side. Again, the Wilcodontics calls for the use of the burr. The piezocision asks for the use of the piezo instrument, the piezoelectric knife. Those are two very different animals. It appears as if the piezoelectric knife makes a smaller cut in the bone, but yet has a much more powerful demineralization effect than the burr does. Though doing the minimally invasive piezocision gives you the same amount of result, you know, when you're an orthodontist, as the more aggressive Orthodontics, because the technology used is different, and the patient acceptance is much higher, and the trauma is much less.
Yes, that's really great, because people won't accept that extensive procedures, and this one is much more acceptable to the patients, and it's easier and less complications for us.
Absolutely, 100%.
Thank you so much.
Because, for example, if I may continue on this this topic, sometimes the orthodontist will ask for an extra boost, you know, of demineralization in one area of the mouth. So the patient will come for a piezocision that takes 5 minutes, okay, to give the orthodontist 6 more months of work. No patient that I know will sit twice for the whole full mouth, you know, orthodontics. That, you know, unless they, you know, they have some, you know, I haven't seen that.
Yeah, we are also doing one this study with our orthodontic teammates, and we are doing like with the smaller incision.
Fantastic, excellent, very good, very good, very good.
Thank you, sir. Thank you so much, sir.
Sure.
Gerard, there are a couple of questions there. One is from Nikhil. While you're looking at that and maybe priming it, preparing it, I want to jump on with Nico's question, which is for Dr. Dibart, and it says, how root surface damage be minimized in the severe crowding cases? And before you address that, I want to add on to that. Obviously, I was very interested in such a simple but beautiful idea of having a guide fitting there just to give you the address where you're going to do this. In your practice, is this a beginner's curve issue, or do you use in majority of the cases and you feel it should be part of the practice?
I've been doing this for like 12 years now, so I really don't even use guides anymore. You can start with a guide that's also obviously very safe and very elegant, and it gives you also a good level of comfort for yourself. The only thing you have to be careful with the guide is the irrigation. So if you're using the guide, you have to have an extra syringe next that the assistant has that's going to irrigate the tip of the piezo knife. That's a very good question. Yes.
Thank you. Any other suggestions if you're not using a guide? Any other suggestions to minimize?
Yes. Yes. Thank you again. This is an excellent question. Studies in rats have shown that the effect of the piezoelectric demineralization goes a tooth and a half beyond the cut. So if you are very, very close, if two teeth are very close, you can skip one. And the demineralization will convene into the middle.
Excellent.
Yeah.
Thank you very much. Gerard, maybe you
can...
I
think from the chat, Nikhil's question, maybe more for Dr. Keser, with regards to scarring post-treatment following the Piezocision, but also about your protocol for changing the wire every 2 weeks.
Yes.
In one of your cases. Is that normal for your protocol?
Yes. So basically, the whole idea is, you know, having a different bone density, a different speed also, and the response to orthodontic force is different. So what we are doing is changing, doing the activations every 2 weeks instead of every 4. So with fixed braces. With aligners, changing the aligners every 3 to 4 days, depending on how many hours the patient is wearing the aligners. So everything is accelerated also in means of the orthodontic adjustments. So if it's an aligner case, they switch to the next one every 3 or 4 days. If it's fixed braces, then we see them every 2 weeks in the clinic, or we, you know, put the protocol according to that. So there's a constant active force. I hope that answers it. And for scarring, if there's any concern about scarring, sutures can be placed. The majority of the time we don't see any scarring if there's no if we stay in the attached gingiva. If you go to the mucosa, then definitely we need sutures, and Dr. Dibar may want to add something on that, but in my experience it's very minimal to get to see scarring at the end of the healing process.
Agreed. Agreed.
Okay. Thank you, Dr. Dibar. And Rahul, do you want to unmute yourself? You've got your hand raised.
Very good evening to all the elite speakers on the forum. I'm Dr. Rahul. I'm a second-year perio resident in India. So my question is, we may have different thickness of the gingival biotypes. And Dr. Surge's protocol say that we have to do corticotomies of almost 3 millimeters, and the piezo knives are marked for 3 millimeters. Now, if we were to have a thick biotype and we are doing a minimally invasive incision, how do we ensure that our corticotomy is 3 mm deep with a thick biotype? Because it's minimally invasive, so we are not seeing the cortex. How do we ensure that?
That's, again, a very good question. Thank you. We use a probe. I always ask my residents for this very specific purpose that you said. You take the probe and you see if you are reaching the medullary bone. If you have not, then you keep going until you reach the medullary bone, because sometimes the cortex can be as thick as 4 millimeters. Okay, so therefore it's very important then you check your ostectomies or your decortications with the probe. And if the probe sinks into the medullary bone, then you're good. The key is to pass the cortex. The 3 millimeters is an average number based on CT scans, hundreds of CT scans, but it's an average. Some people have thicker cortex than others. The best way to evaluate that on an individual person basis is to use a parental probe and then to make sure that you are into the medullary bone.
So with the probe, the tactile sensation for the medullary is a little different than the cortex.
Yes. And the way you do that is very simple. Actually, you take the probe and walk the probe against the side of the osteotomy. It's gonna be hard cortex, and all of a sudden it's gonna drop into something soft, and that's when you know that you are in the medullary bone.
Understood. Thank you very much, Dr.
You're very welcome. You're very welcome. We are planning to do a hands-on eventually later, when things are better, so that we can show you, in real time on animal models how to do it, well, and then you can sense all these nuances.
I hope to join those sessions.
Thank you, Dr. Rahul.
Thank you.
A couple of questions just about bone grafting, Dr. Dibar. One is about what material. This was sent to me directly. What grafting material do you commonly use alongside this procedure? And then it's about there might be fenestrations and dehiscence as no bone grafts are used. So a little bit of a couple of points just to clarify on indication for bone grafting and then also materials.
Yeah, well, the bone grafting that we use is an allograft, a human allograft, demineralized, freeze-dried, or cancellous bone. That's what we use. Some people use bios, which is a xenograft. I do not. I prefer the human bone, be it autogenous or an allograft. In terms of fenestration and dehiscences, that is correct. But those are prevented by looking at the cross-section on a CT scan and sitting with your dentist and asking which type of movement are we doing? Are we proclining the teeth? Yes, no. Are we moving buccally the teeth? And then you look at the CT scan. If you have very little bone or alveolar bone there or no bone at all, then you know you have to place a graft. Otherwise, you're gonna have a recession coming up. So all this is part of the planning session that goes before the surgery, talking with your dentist, so that during the piezocision process, you are equipped and ready to place a bone graft. And very often we put a placement, very often in the lower canine to canine, very often because the orthodontist procline these teeth. And most of the time you have, even before you start, you know, if you were to lift the gingiva, you will see the descents and recessions right there. So an orthodontic treatment will make that worse. So therefore, we always put, you know, 90% of the time bone in those areas.
Okay, thank you for clarifying that.
You're welcome.
I think that's pretty much it. There's some specific questions about protocols and things, but Dr. Keser, that may well be covered better in the course. I imagine there are some real specifics to that. There's no one size fits all. So do you agree, Elif?
Yes, and also, you know, anyone who's interested can do a very quick PubMed search, you know, look up Dr. DeBar's articles or mine that were published, where there are some case reports, some review articles that are already out there, so you can easily have a read through those and, you know, just come back to us with any questions, and the course will be very helpful in getting into a lot of detail in different scenarios as well. So it's not like, you know, one protocol fits all, but there has to be some little tweaks. And as Dr. DeBar said, it's like a game of chess. So for each patient, you have to also understand the basics and then plan accordingly. So it's really important to understand the basics and then devise your protocol against that. But for the simple understanding, please go ahead and do a PubMed research. You'll find a lot of articles published by myself or Dr. DeBar and Dr. Nelson that lays out the protocols that we are using.
Thank you. Thank you. I think that covers all the chat questions that I can see, and there's no one else with their hands up. So if we all agree, I'll bring this to a close. And thank you very much to our speakers this evening. Dr. Nelson has left, but to Dr. DeBar and to Dr. Keser for fascinating presentations, beautifully illustrated, and a really interesting topic that certainly has got my mouth watering. I want to learn more about it. So thank you so much for that. And I will just again, Memo, any closing comments from you?
Just a reminder, Gerard, that we will, with the permission of the speakers, we will make this accessible online on our website, so that you can have a revisit to look at you know, some of the concepts discussed this evening. And also, as you know, many people registered. We've been running these courses. It's such a difficult thing to attend sometimes. It will give opportunity to some of the registrants who couldn't attend tonight to have a look at it. So just watch out for our website to maybe revisit this talk.
Yeah, thank you, Memo. Thank you very much, and good evening to everybody.
Thank you.
Bye-bye. Bye-bye.
Thank you so much. Take care.
Thank you.